They don't need to feel either that they're being abandoned. If at all possible, and I know our company was called a lot of times in ahead of time, we'd love to go in before the child gets discharged to introduce ourselves to the parents, to make sure that everything is working well, and that they're going to be expecting us, get to know the child a little bit, get to know the routines of what's going on in the hospital. This all helps for a smooth transition. Care of the child and family in special hospital situations. Ambulatory or outpatient care. There's benefits to it. Like I told you before, no nosocomial infections. When you are in and out, that's the best way to have it. Preparation of the child can be challenging. The stress of waiting. Explicit discharge and follow-up instructions. You get very little time to tell that parent or the significant other, whoever is going to be providing care for that child, all that needs to be done. You get a short amount of time. You have a piece of paper that they go out of the hospital with, and you need to make yourself available and let these parents know that if they have any questions, they can call back to the unit and someone there will be able to answer their questions, because we throw so much information at them at the time of discharge, and they're thinking, I got to get the car seat, I got to do this, I got to do that, I got to stop by the drugstore on the way home and get the prescriptions filled, I got to meet the children off the school bus that we left at home. So there's a lot going on in their mind when this discharge comes up. So that we need to make this as smooth as possible for them and be there for them when they get home and they look at the piece of paper and they don't understand a thing. And this happens a lot. Isolation. Added stressor of hospitalization. The child may have limited understanding. It's hard to make a little guy understand why they're in this strange place, why they're in pain, why they don't feel good. And now we don't have any mommy and daddy and no mom and no other brothers and sisters. And it's very hard for them to understand. They may have fears. They're in a strange environment. They might have nightmares. They hear strange noises. And then we do those wonderful things to them when we expect them to be asleep and go to sleep and be comfortable in this environment, and we go in and we draw labs on them at 6 in the morning and we stick them with things and we do treatments to them. This is not the place to do this at their bed. That's why I love going to the treatment room, and like I said, it's healthy when a child will fight you if they know that they're going to that treatment room and you're going to do suctioning on them and they fight you all the way. That's a healthy response from a child. You don't want a child that just lays back and lets you do anything that you want to them, because that's a child that's really troubled. Potential for sensory deprivation. They don't have, maybe they don't have all the stimulus that they have at home. They certainly don't have the social stimulus. And we can come in and check in on them, but they don't have all of the toys that they have. They don't have their nice little things from, all their nice things from home. So, and we turn out the lights on them, and we put machines on them, and we restrict a lot of their movements a lot of times. So things are quite difficult for them to adjust to. Emergency admission. Essentials of admission counseling. Postvention, counseling after the event, and participation of child and family is appropriate. Emergency admissions are really, not the best way to come into the hospital. It's very confusing. Things happen fast. They go from being sick to being admitted. That means they're really sick, and they've gotten acutely ill fast. It's confusing to them. The parents are stressed. They can just look at their parents' face and tell that their parents are very, very upset, and that scares them too. Intensive care unit. Increased stress for child and parents. Intensive care. It is what it says. This is life-threatening illness. When you go to the intensive care, it's a life-threatening situation. Families' emotional needs are not being met, and we need to see that the parents, a lot of times they pull vigils around that child's bed, and we need to make sure that they take care of themselves. They take a little break and get something to drink. They get some rest. They take care of themselves because we don't need two patients, and we tell them that too. We tell the parents, if you don't take care of yourself, you're going to be the next patient here. You need to take care of yourself. You need to get your rest. You need to do what you have to do to take care of you so that you can take care of your child. They need information, and sometimes we don't have the information to give them. We need to wait this out. Sometimes we need to wait for the test results, and when it's your child, it's forever until that blood work comes back. It's forever until that someone can come and read the results of the sonogram or something else that you've had done. Perception of security from constant monitoring and individualized care. They do. They think they're pretty secure in that hospital, and we allow them to think that too, because we want them to think that. They don't like it. They don't want to leave their child, but sometimes it's necessary. And at least if they're in an intensive care unit, they know that they're getting one-on-one care or one-on-two care, that somebody is monitoring them at all times. And that makes them feel a little bit more comfortable too. And this is Wong's chapter 23, The Child with Respiratory Dysfunctions. General aspects of respiratory infections. There's upper respiratory infections, and they include the nose and pharynx. There's lower respiratory tract, which is the bronchi and the bronchioles, deep down in the chest. Croup symptoms, infections of the epiglottis and larynx. Infectious agents. We have viruses. We have RSV, and that usually is for, like our preemies have a lot of problems with this. And there's a vaccine out now that they give premature children. And children up to, I think it is 2 or 3, that get this RSV. And it comes on looking, for a child that's home, it looks like a cold. Other infectious agents are group A hemolytic streptococci, staphylococci, chlamydial trichomonas, mycoplasma organisms, and pneumococcal. Haemophilus influenza. Infants of 6 months or less have maternal antibodies. From 3 to 6 months, infection rates increase. Toddler and preschoolers, their high rate of viral infections. Think of what they're doing. They're sharing their secretions. They've got their hands all over their nose and mouth, and they're hugging and licking and doing all these toy grabbing. And if they're in an environment like a daycare center or school, a preschool, you can understand how rapidly those germs are going around. 5 years, above 5 years is increase in mycoplasma pneumonia and B streptococcal infections. Increased immunity with age. So once we get a little age on us, if we're in good health, we should be able to fight off a lot of these infections. Size. The diameter of airways is very, very small on small children. The distance between the structures is shorter, allowing organisms to rapidly move down. Short eustachian tubes, too. This is what causes all those nice ear infections and otitis media. Resistance. Our immune systems, sometimes, especially in preemies and children that are fragile, that have immunodeficiency disorders or any kind of chronic illness, makes them more vulnerable. And their immune systems aren't as good as a child that is healthy. Allergies from asthma, cardiac anomalies make them very vulnerable. Cystic fibrosis, those poor children, they're very vulnerable. And daycare. Seasonal variations, most common during the winter and spring. Mycoplasmal infections, more common in fall and winter. Asthmatic bronchitis more frequent in cold weather, and RSV season considered winter and spring. Clinical manifestations of respiratory infections. They vary with age. Generalized signs and symptoms and local manifestations differ in younger children. There's fever, anorexia, vomiting, diarrhea, abdominal pain, cough, sore throat, nasal blockage or discharge, respiratory sounds. You can actually put your hands on a child's chest a lot of times and feel it gurgling and rumbling. And you can hear when they breathe, especially the children that have asthma. You can really hear them. Nursing interventions for respiratory infections. You want to ease the respiratory effort. You want to take that struggle to breathe away from them. You want to manage their fever, promote rest and comfort, infection control. That might mean antibiotics. It might mean breathing treatments. It might mean steroids. Promote hydration and nutrition. We want to thin those secretions. When we thin those secretions, it makes it easier for them to cope with. And family support and teaching. We always, always are the teachers. Upper respiratory tract infections, URIs. Nasopharyngitis, which is the common cold. It's caused by numerous viruses, RSV, rhinovirus, adenovirus, influenza, and parainfluenza viruses. Fever varies with the child's age. Home management, that varies with the child's age too. Sometimes we can manage it at home and sometimes we can't. Usually, a small infant that gets RSV that's not manageable at home, we bring them to the hospital because they really are struggling. If a child's like 5 or 6 years old and they can cough and they can blow their nose, it helps to be able to bring up these secretions, and that helps also to with the management. Pharyngitis, causes and risks viral or bacterial, and it's called GABHS. Can cause permanent damage and need to be diagnosed and treated. Clinical manifestations can be asymptomatic. Diagnostic, the rapid strep test. Therapeutic management is penicillin. Nursing considerations, age and ability of the child determine treatment modalities. Sometimes they have to take shots because they're not going to be able to keep the medicine down. Sometimes they're not going to be compliant, and we have to do things a little bit differently. Here's pharyngitis. There's the tonsils and the uvula, and look at all that infection. Tonsillitis and pharyngitis. Tonsillitis. Pathophysiology and etiology of inflammation, often with pharyngitis, viral or bacterial. We do the rapid tests. Treatment, if persistent and reoccurring, may do tonsillectomy with or without adenoids. They don't take adenoids out automatically anymore. They used to, but they don't anymore. Therapeutic management, prevent hemorrhage for post-surgical. That is the biggest problem of a child with a tonsillectomy, is hemorrhage. Nursing considerations, comfort and restrict fluids until fully alert. Solid food by day 2 post-op. Influenza, good old flu. Clinical manifestations can be mild to severe in infants during winter, most times during winter. Therapeutic management mostly, symptomatic. We only treat the symptoms. We don't over-treat with antibiotics and things that we used to. We just treat the symptoms. May take inhaled medications. Prevention, there's 2 vaccines. And nursing considerations are to relieve symptoms. Otitis media, most common cause of problems in infants and children. Pathophysiology and etiology, winter, bacterial, and are preceded by viral or respiratory infection due to the eustachian tube malfunction. Diagnosis feeding methods of infants' breast feeding as a lower incidence of otitis media. Therapeutic management. Pharmacologic, most common use of